Normally, we trust our immune system implicitly. We walk through a world just covered in pathogens, and our biology handles it without us ever really noticing.
Right. It's completely invisible to us most of the time.
Exactly. But what happens when that system fundamentally misreads the room? What happens when it starts attacking your own healthy tissue? Suddenly, the very mechanism keeping you alive becomes the thing destroying your quality of life.
And that is a terrifying shift for anyone to experience.
It really is. And that is the exact scenario we are unpacking today. Welcome to this deep dive. We are looking at lichen sclerosus, a really complex autoimmune condition, to answer a massive medical question. Can immunosuppressive drugs actually halt this disease?
Right. And to figure that out, we're digging deep into the major clinical guidelines. Specifically, we've got the British Association of Dermatologists, the Euroguide Derm Standards, and a whole stack of recent randomized clinical trial data.
So setting the stage for you, the stakes with lichen sclerosus or LS are incredibly high. The sources define it as a chronic, progressive, inflammatory mucocutaneous condition.
Yeah, and breaking that medical jargon down, mucocutaneous just means it targets the areas where mucous membranes meet regular skin.
Mostly the genital and perianal regions, right?
Exactly. Though it can show up on the torso or breasts too. It causes this intense, unyielding itching and deep soreness. But the real danger is what happens over time if that inflammation just runs rampant.
Yeah, the tissue undergoes these severe anatomical changes. The skin physically scars, it thins out, and it can literally fuse together.
It's devastating for the patient's anatomy.
Completely. And beyond the daily pain, there is a very real, albeit small, risk. We're talking under 5%. But a risk that this chronically inflamed skin can develop into squamous cell carcinoma.
Which is a type of skin cancer.
Right. So the goal of any treatment here isn't just, managing a rash. It's about fundamentally shutting down that rogue immune response to prevent permanent disfigurement and malignancy.
Which forces medicine to rely on drugs that deliberately suppress immune activity.
Which sounds totally counterintuitive, right? Like weaken the immune system to save the patient.
It does sound backwards. But in cases of severe autoimmune overdrive, it's really the only way to protect the tissue. The medical guidelines lay out a very clear hierarchy of how to achieve this, and it starts with a heavily established baseline.
Yeah, before any of the novel or highly engineered treatments are considered, the absolute gold standard for LS is ultra-potent topical corticosteroids.
Specifically, clobetasol propionate 0.05% ointment.
The data on clobetasol is just staggering. A 3-month proactive course results in complete remission of symptoms for about 60 to 70% of patients.
That's a massive success rate for a topical cream.
It really is. It broadly switches off the pro-inflammatory genes, it stops the scarring, and it actively reduces that risk of malignant change we mentioned. It's essentially, well, think of it like throwing a heavy, dense fire blanket over a grease fire in your kitchen.
I like that analogy.
Yeah, it suffocates the localized inflammation beautifully. But okay, let's unpack this for a second. If clobetasol works that well and actually prevents cancer progression, why are we even exploring other immunosuppressants?
Right. Why fix what isn't broken?
Exactly. If the fire blanket puts out the fire, why look for a different tool?
Because a heavy fire blanket isn't a flawless solution if you have to leave it on the stove permanently.
Oh, that makes sense.
Yeah, clobetasol is highly effective, but it is a really blunt instrument. When you use ultra-potent steroids continuously over a prolonged period, they interfere with collagen production.
Oh, right.
This leads to a side effect called atrophy, which is a severe thinning of the skin. And you have to remember, genital skin is already inherently delicate.
Right. So if a patient requires near constant application to keep the symptoms at bay, we risk curing the inflammation but structurally degrading the tissue in the process.
Exactly. And there is a significant subset of people who just don't respond to the fire blanket at all.
Wow.
Yeah, the clinical trial data indicates that between 4 and 10% of patients have steroid-resistant LS.
So they apply the clobetasol, and the autoimmune fire just keeps burning right through it.
Unchecked. Or they develop a severe contact allergy to the base ingredients of the ointment itself. So when that baseline fails, or when the skin starts showing signs of dangerous thinning, doctors urgently need an alternative way to put out the fire.
And that necessity has driven dermatology toward a completely different category of drugs. We move away from the broad suppression of a steroid and look toward highly targeted intervention.
Yes, the topical calcineurin inhibitors, or TCIs.
The two major compounds used in this space are tacrolimus, which is often prescribed as Protopic, and pimecrolimus, known as Elidel. And honestly, the biological origin of these drugs is absolutely wild.
It's one of my favorite medical origin stories.
It's so cool. Tacrolimus wasn't synthesized from scratch in some pristine pharmaceutical lab. It was discovered back in 1984, isolated from a sample of dirt found in Japan.
Just a random soil sample.
Right. It's produced by a soil bacterium called Streptomyces tucubiensis. In the wild, this bacterium uses tacrolimus to fight off competing fungi in the dirt. It evolved as a highly specific biological weapon.
And human medicine repurposed that exact mechanism to calm down autoimmune skin conditions. What's fascinating here is the mechanics of how this soil-derived compound actually works in human tissue. It represents a massive leap in targeted pharmacology.
Okay, break that down for us.
So the localized inflammation in lichen sclerosus is driven by T lymphocytes. Those are specialized white blood cells that congregate in the affected skin.
Right.
For a T cell to trigger an inflammatory attack, it relies on an internal enzyme called calcineurin. Think of calcineurin as the final switch in the cell.
Okay, the final switch.
When it flips on, the T cell starts manufacturing and releasing inflammatory cytokines, specifically interleukin-2.
So calcineurin is basically the cell's internal megaphone, shouting the order to attack the surrounding tissue.
That is an excellent way to conceptualize it. When you apply tacrolimus ointment to the affected area, the drug molecule penetrates the skin and slips inside those specific T cells.
Oh, wow.
Yeah, it binds to an internal protein complex. And that resulting structure physically locks onto the calcineurin enzyme, disabling it entirely.
So it acts like a localized Wi-Fi jammer.
Exactly.
The T cells are still physically sitting there in the tissue, but their communication network is completely severed. They can't transcribe the genes to create interleukin-2, so the inflammation stops right at the source.
And it does all this without shutting down the immune system across the rest of the body.
Which is huge.
Yeah.
And the results are incredibly promising. I mean, look at the multi-center phase 2 trial conducted by Henge and his team. They took 84 patients with active, long-standing lichen sclerosus.
These are people deeply suffering from the condition.
Yeah, really struggling. They prescribed a 0.1% tacrolimus ointment. And after 24 weeks, 77% of the evaluable patients had a positive response.
That's a solid number.
It is. But more importantly, 43% achieved a complete remission of their symptoms.
Achieving complete remission in over 40% of long-standing cases with a non-steroidal treatment is a major clinical victory.
Absolutely.
And because TCIs don't interfere with collagen synthesis the way steroids do, they carry zero risk of causing skin atrophy.
So you can use them on delicate mucocutaneous tissue without fearing that the skin will structurally degrade over time.
Precisely.
But, every time we find a seemingly perfect medical solution in these deep dives, there is a catch.
There's always a catch.
Always. If these localized Wi-Fi jammers are so effective and they completely avoid the skin-thinning side effects of steroids, why do the European and British guidelines uniformly classify them strictly as second-line treatments? Why aren't they the very first thing doctors prescribe?
To answer that, we have to look at the head-to-head clinical data. Elegant biological mechanisms are great on paper, but the messy reality of patient outcomes dictates the guidelines.
Right, the real-world application.
Exactly. We have this highly rigorous 2011 double-blind randomized controlled trial by Goldstein and colleagues. They took patients with vulvar lichen sclerosus and directly pitted the steroid clobetasol against the calcineurin inhibitor pimecrolimus.
Okay, the ultimate showdown.
Yes. The trial ran for 12 weeks.
And my immediate assumption reading the mechanism was that the advanced targeted jammer would outperform the blunt fire blanket.
Most people would assume that.
Right. Both groups clearly saw significant relief. The itching and burning subsided for most patients across the board, but they included microscopic biopsies of the tissue before and after the 12-week period to see what was actually happening at a cellular level.
And what did the biopsies show?
The results showed that clobetasol was actually slightly superior at reducing the deep tissue inflammation. The steroid cleared the underlying cellular infiltrate better than the targeted TCI.
Which secures clobetasol's position as the undisputed first-line treatment. It is simply more potent at halting the disease process deep within the skin layers.
It's hard to argue with the tissue samples.
It really is. But the slightly lower efficacy isn't the only reason TCIs remain in the backup position. There are two very specific hurdles, one physical and one theoretical, that complicate their use.
Oh, right. The physical hurdle is brutal for compliance. When a patient first applies tacrolimus or pimecrolimus to skin that is already raw, cracked and inflamed from lichen sclerosus,
Right.
it burns.
Yes, intensely.
Sometimes it causes this intense, localized stinging sensation that can last for hours. It's a known reaction, often tied to the release of certain neuropeptides in the skin, and it usually fades after a few consistent days or weeks of use.
Right, the skin adjusts.
But, I mean, think about it. If you hand a tube of ointment to a patient who is already in agonizing pain, and that ointment makes them feel like their skin is literally on fire for the first week, they're highly likely to throw it in the trash.
And if the patient abandons the therapy on day 3, the drug's fancy mechanism is irrelevant. Managing that initial burning requires extensive patient counseling, which makes it a harder drug to deploy than a soothing steroid ointment. But the second hurdle is much heavier. It involves a long-term theoretical risk that has actually resulted in these drugs carrying a black box warning from regulatory agencies.
Which sounds incredibly intimidating, and this comes back to the cancer risk, doesn't it?
It does. Lichen sclerosus natively carries that small, under 5% risk of developing into squamous cell carcinoma because the chronic inflammation makes the local skin cells genetically unstable.
Exactly the problem. And one of the primary jobs of those localized T cells is tumor surveillance.
Right, they patrol the tissue looking for cells that have mutated. If they spot a precancerous cell, they destroy it before it can multiply.
So when we apply a calcineurin inhibitor, we are deliberately blinding that local immune response to stop the autoimmune attack. But the theoretical fear is that by disabling the T cells, we might also be switching off the body's natural ability to detect and destroy an emerging skin cancer.
Exactly. We might fix the painful inflammation, but inadvertently roll out the red carpet for a malignancy.
But, and this is crucial, it's critical to look at what the longitudinal data actually proves versus what we fear. The evidence connecting topical calcineurin inhibitors to an increased rate of cancer in lichen sclerosus patients is incredibly weak.
Very weak.
Yeah, broad observational data over the last decade shows almost no foundation for this fear in practical application. However, because the underlying disease is already premalignant, regulatory bodies and major dermatological guidelines exercise extreme caution.
And they should. The Euroguiderm guidelines are very explicit about this. While a direct causal relationship to cancer hasn't been established, the theoretical risk demands that the long-term safety profile be heavily monitored.
Better safe than sorry.
Exactly. Therefore, TCIs are brilliant, highly effective tools, particularly for steroid-resistant patients or for maintaining remission once a steroid has done the heavy lifting. But they require specialist supervision, and they remain firmly second line.
So we have the heavy fire blanket of steroids and the localized Wi-Fi jammer of TCIs. Both are topical creams. But what do you do when the disease refuses to stay localized?
That's where things get really complicated.
Yeah, the guidelines highlight severe, highly recalcitrant cases. Sometimes lichen sclerosus spreads far beyond the genital region, showing up as widespread extragenital lesions across the back, torso, or under the breasts.
Or the localized version is just so aggressive that it completely ignores both steroids and TCIs.
Right. In those extreme scenarios, we have to acknowledge that the immune dysregulation is too profound to be managed from the outside in. We can't just treat the surface of the skin. We have to alter the environment of the entire body.
We have to escalate from local topical suppression to systemic immunosuppression.
If the topicals are a localized fix, systemic oral medications are like shutting off the main water valve to the entire house just to fix a leaky faucet. You're circulating powerful drugs through the bloodstream to turn down the volume on the entire immune system.
And the guidelines do not take this lightly. The primary systemic option discussed is methotrexate.
Okay, let's talk about methotrexate.
It's an antimetabolite. To understand why it works for severe skin inflammation, you have to look at how cells reproduce. Rapidly dividing cells, which absolutely includes hyperactive immune cells driving an autoimmune attack, require massive amounts of folic acid to synthesize DNA and replicate.
Okay.
Methotrexate physically blocks the enzyme responsible for folic acid metabolism. By starving these rogue immune cells of the folate they need, it abruptly halts their ability to multiply and sustain that widespread inflammation.
It's highly effective for severe extragenital lichen sclerosus. But because it impacts folic acid metabolism system-wide, it also affects other rapidly dividing healthy cells.
Yes, there's collateral damage.
Right. That's why it carries significant toxicity risks and requires rigorous continuous blood monitoring to ensure your liver and kidneys are handling the medication safely.
And there are a few other systemic options in the toolkit, such as oral cyclosporin, which suppresses T-cell function system-wide, and mycophenolate mofetil.
But all of these require intense management, don't they?
Oh, absolutely. They are severely teratogenic, meaning they can cause profound birth defects, so any patient of childbearing age must adhere to strict contraception. They are the definition of a last resort, managed exclusively by highly specialized dermatologists.
And this brings us to the most cutting-edge tier of systemic medicine. Here's where it gets really interesting, because the biology takes a truly bizarre turn. Beyond traditional immunosuppressants, we have biologics.
These are
They
fascinating.
aren't broad chemical suppressants. They're intricately engineered proteins designed to target single, specific inflammatory pathways in the body. A major class of these are TNF-alpha inhibitors, like the drug adalimumab.
Right, and TNF-alpha is a master inflammatory cytokine. It's a major driver in systemic autoimmune conditions like severe psoriasis or Crohn's disease. By injecting an engineered protein that neutralizes TNF-alpha, we can often shut down massive inflammatory cascades with incredible precision.
So logically, targeting TNF-alpha should be a silver bullet for severe recalcitrant lichen sclerosus or closely related conditions like erosive lichen planus.
It should be. But the clinical data reveals a staggering paradox. Doctors prescribe these highly advanced TNF-alpha inhibitors to suppress the immune system and heal the skin.
Right.
Instead, there is a rising documented trend of these exact biologic drugs actively inducing severe lichen planus-like eruptions.
That is wild. You introduce an immunosuppressant to calm the tissue, and the drug itself triggers the exact mucocutaneous inflammation you are trying to avoid.
It is a profound biological contradiction. It's the equivalent of calling the fire department to put out a blaze, and the moment the trucks arrive, they spontaneously combust and make the fire worse.
Oh man, that's a perfect way to describe it.
It completely upends the simplistic logic of suppressing the immune system cures autoimmune skin disease.
So what does this all mean? If you're staring down a diagnosis of lichen sclerosus, looking at this vast landscape of treatments, the ultimate takeaway is really a massive ladder of hope.
Absolutely.
Immunosuppressive drugs absolutely can treat this condition, and you are not limited to one single option. You start with the proven heavy suppression of topical steroids to halt the scarring and reduce cancer risk.
Right.
If the skin thins and the disease resists, you step up to the precision of soil-derived calcineurin inhibitors to jam the local signal. And if the disease is systemic and overwhelming, the medical field has powerful system-wide drugs ready to deploy.
The toolkit is incredibly deep. And knowing that hierarchy means knowing that an initial failure is just a signal to move to the next rung on the ladder. There is almost always a pathway forward to reclaim a patient's quality of life.
Yeah, that's so reassuring. But you know, that paradox with the biologics really sticks with me. We spent decades engineering these incredibly complex molecules to micromanage the immune system, and sometimes they backfire spectacularly.
It really highlights how much we still don't know.
It makes you wonder if our entire paradigm of suppression is eventually going to hit a wall. I mean, if tacrolimus came from a soil bacterium trying to survive, it implies that the microbiome, the bacteria naturally living on our skin, has a profound ability to communicate with and regulate our local T cells.
That is a fascinating way to look at it.
Right. What if the future of treating conditions like lichen sclerosus isn't about throwing heavier pharmacological blankets or systemic jammers at the problem? What if the key lies in mapping the skin's microbiome? And rather than suppressing the rogue immune cells, we use bacterial compounds to naturally retrain them.
It leaves you wondering if the ultimate cure is already living right on the surface of our skin, just waiting for us to understand its language. Are we truly controlling the immune microenvironment, or are we just playing a highly sophisticated pharmacological game of whack-a-mole?
That is a wild thought to end on. Thanks for joining us for this deep dive.